Welcome, ladies and gentlemen. I'm Dr. Silva. Thank you for joining me for this talk on the benzodiazepines, a class of medication known colloquially as benzos. These are the PAM sisters: diazepam, clorazepam, clonazepam, alprazolam, triazolam, oxazepam, etc. All except for transine, clorazepate, and Librium, the first benzodiazepine, chlordiazepoxide. This family of medications was also once called the minor tranquilizers, except they had nothing in common really with the so-called major tranquilizers, which are the antidopaminergic conventional antipsychotic agents like Haldol and Thorazine, medications which are about as antiquated as that nomenclature. Benzos actually have more in common with the barbiturates, which I will review in a moment. The chemical structure of a benzodiazepine is the fusion of a benzene ring and a diazepine ring. And the first agent, Librium, was discovered, like so many psychotropic agents in the 1950s, completely by accident. It was synthesized in 1955, marketed in 1960, and followed by Valium, diazepam, 3 years later. By 1977, benzodiazepines were the most prescribed medications in the world. And they're still some of the most popular because they're so safe and effective. The mechanism of action is that these agents ultimately increase the action of endogenous GABA, gamma-aminobutyric acid, the major inhibitory neurotransmitter in the central nervous system. They do this by binding to the GABA-A receptor subtype. And the exact mechanism of action is really fascinating, and I think this is so amazing that we figured this stuff out right down to the molecular subunits. This is a bit esoteric, but it's too interesting to skip. The GABA receptor is a protein comprised of 5 transmembrane units which traverse the cell membrane 5 times, and which collectively shape a chloride channel in the center. When a benzodiazepine binds to one site on the A receptor, it causes a conformational change in the physical structure of the receptor, which, remember, is a protein, such that it increases the affinity of that receptor for the binding of endogenous GABA at another site on the receptor. So benzodiazepines are at one site, they bind, the receptor changes conformation, and that increases the likelihood that GABA is going to bind to another site. That process is called allosteric modulation, positive allosteric modulation. So benzodiazepines don't stimulate the receptor. They're not agonists. They're positive allosteric modulators of the receptor, such that endogenous GABA binds with greater affinity to the receptor, and this obviously increases the actions of GABA, which leads to sedative hypnotic, anxiolytic, anticonvulsant, and muscle relaxing properties when chloride anions flood into the cell via the pore. Chloride anions through that pore, the channel created by the receptor protein. Because chloride has a negative charge, it has a charge of -1, this influx of chloride into the neuron cells hyperpolarizes the cell membrane, which is an esoteric way of saying that it takes a stronger stimulus to depolarize or activate the cell and to get the neuron to fire. I'll skip the neurophysiology here. Don't worry if some of these terms are unfamiliar to you. Just know that less firing leads to lower arousal. And that includes any fear or anxiety that is a part of that alertness. Inhibitory actions at the level of the spinal cord may provide therapeutic benefits for muscle spasms because numbing those neurons also relaxes the muscles innervated by them down the line. And benzodiazepines can stop a withdrawal seizure or any kind of seizure in its tracks due to inhibitory actions in the cerebral cortex. Finally, inhibiting neuronal activity in the fear circuits of the amygdala in the limbic system is thought to provide the anxiolytic, fear-busting therapeutic benefits that we see with anxiety disorders. This mechanism of action is identical, by the way, to the non-benzodiazepine class of hypnotic agents that includes Ambien, Sonata, and Lunesta, zolpidem, zeleplon, and ezopiclone. Clinical effect is a matter of degree. At low doses, these agents reduce anxiety. They're anxiolytic. At higher doses, they're sedatives. And at still higher doses, they induce sleep, which is what is meant by hypnotic in the term sedative hypnotic. Of course, significant tolerance to the sedating effect of these medications is a given, which is why sleeping pills often fail after a period of time. But this is often because they're being taken improperly. There is a way to preserve the efficacy of sleeping medication that involves good sleep hygiene and taking the medication judiciously. I have a video on that. Please check out how to make your sleeping pill keep working for insights there. But the anxiolytic properties do not fade, not beyond a certain measure. And that's important to remember when dosing these medications for anxiety, especially during the day. I often see doses that are way higher than necessary, especially with Xanax, because we're chasing euphoria, chasing a side effect, really, what I call a supra-therapeutic effect. And I have a video on that as well. Please check out Xanax, everybody's favorite. But it's important to know that although you do get tolerance to the sedative effect, and eventually you could take really high doses and not be sleepy and still be lying in bed wide awake with insomnia, you're going to be calm. You don't develop tolerance to the anxiolytic effect, so that if you're very nervous or you're having a panic attack, you don't get to a point where you have to keep increasing the dose and keep increasing the dose to treat that. That stays treated at very low doses. And yet I see clinicians escalating the dose of Xanax because really the patient's complaining, they're losing efficacy, but really what's happening is they're gaining tolerance to the euphoria. And they confuse that with the therapeutic effect, or they want the euphoria. Anyway, there's a separate video on that, please check it out. But because these medications only increase the action of endogenous GABA and don't directly stimulate the receptor itself, as GABA does, these are receptors on GABAergic neurons, neurons that use and respond to GABA, there's a ceiling effect. Even in significant overdose, when most or nearly all of these receptors are saturated with benzodiazepine, there's only so much endogenous GABA to go around. And so respiratory depression to the point of asphyxiation is very rare in the absence of combining them with other agents, such as opiates or alcohol, all of which likewise depress the respiratory drive or in other extenuating circumstances. This is in contrast to the barbiturates, the barbitol family, phenobarbital, pentobarbital, secobarbital, amylbarbital, butalbital, etc., that, like the benzodiazepines, differ primarily on the basis of their half-lives, whether they're long-acting or short-acting preparations. Their mechanism of action, and why they're so fatal in overdose all by themselves, is that when barbiturates bind to the GABA receptor at their own site, a site different from where benzodiazepines and GABA itself bind, so this is a third kind of site, they're also positive allosteric modulators, increasing the affinity of GABA for this receptor at GABA's site. But at higher doses, barbiturates are also direct agonists of the GABA-A receptor, stimulating it directly. And so they're much more dangerous because they don't rely solely on the amount of endogenous GABA available to that receptor. Rather, they mimic GABA themselves. So if you give enough, you'll have a much greater saturation of these receptors throughout the central nervous system and in sufficient quantities, enough to completely depress respiration, leading to coma, central asphyxiation, and death. So the benzodiazepines were much safer than the sedatives that came before. The barbiturates were prescribed a great deal until the benzodiazepines came along, and they remain among the safest of medications so long as they're not abused or combined with other sedatives or alcohol or intentionally taken in overdose. The risks are really not that one will stop breathing and die, even if you take practically the whole bottle. The real dangers are at much lower doses: falls in the elderly, poor judgment while under the influence due to disinhibition, anterograde amnesia, Anterograde meaning occurring after dosing as opposed to retrograde. So you might forget what you do and say after you dose, i.e. a blackout, just like with alcohol, but you're not going to forget what you did or said before you took the medication. These agents impair short-term memory. Driving and operating heavy machinery while under the influence, and other perils of intoxication. But most of those perils are indeed when the dose is too high or when the medication is not being taken judiciously. Taken responsibly, they're extremely safe. There is a mandatory FDA black box warning, the most severe warning the FDA issues, regarding the increased risk of CNS depressant effects, central nervous system depressant effects, when benzodiazepines and opioid medications are used together, including specifically the risk of, quote, slowed or difficulty breathing and death. In 2020, the FDA updated the black box warning for benzodiazepines to include information about the risks of abuse, misuse, addiction, physical dependence, and withdrawal reactions. What do we use benzodiazepines for? Well, insomnia. Several are approved by the FDA for short-term use. Long-term use is controversial. I'll get into that in a second. Anxiety, including panic attacks, and social anxiety. They're very effective for social anxiety. In fact, they are my preferred agent. They're really the only thing that can knock out social anxiety 100% for a few hours after you take a dose. Otherwise, individuals with social anxiety tend to have a certain baseline level of shyness and of anxiety. That's a very stubborn symptom, but it can go away completely with a little Xanax, or for that matter, alcohol. But it's because of GABA. It's also used to treat seizures, including status epilepticus, which is a condition of sustained seizure activity, which can be fatal. Restless legs and other forms of akathisia, usually either induced by medication or part of restless legs syndrome. Myoclonus and other muscle spasms, spasticity in general. Nonspecific agitation, psychotic and manic agitation, and agitation due to dementia, but carefully, because not only is there a fall risk for a lot of these individuals, but you can also get a paradoxical reaction in the elderly due to disinhibition and confusion, and so they may actually get excited and more agitated. Benzodiazepines can be used to treat alcohol withdrawal because they're cross-tolerant with alcohol. Individuals that drink a lot can take Xanax for the first time and much higher doses than they would if they weren't heavy drinkers. Of course, they're cross-tolerant with each other, and they're also cross-tolerant with the barbiturates. So they treat sedative hypnotic withdrawal in general. And as far as alcohol, they are very effective for even severe alcohol withdrawal, i.e. delirium tremens, the alcoholic delirious state, which can be fatal as well. I once saw, as a medical student, the only time I've ever seen anybody go into DTs, and it was the classic textbook example of a gentleman who came into the hospital for surgery. And so he's a heavy drinker, drinking every day, heavily, and he's never going into withdrawal because he's never stopping. But he has to stop when he comes into the hospital because he has his surgery, and then he's there for a couple of days. And because he doesn't have access to alcohol and doesn't tell anybody, he starts to go into DTs. And sure enough, he was just sitting there calmly, and the next thing you know, he's shaking. It was really amazing to watch, a progression over a matter of minutes. First, his extremities, his hands. Next thing you know, his whole torso was going and jerking. They gave him 2 milligrams of intravenous lorazepam, Ativan. Didn't touch him. A few minutes later, they followed it with another 2 milligrams of Ativan. Still, he was jerking and shaking, and he was so out of control that he couldn't speak. And so finally, with the third round, 6 milligrams of intravenous Ativan is what it took to calm his withdrawal tremens. It was very, very impressive to see. And finally, catatonia is another indication for benzodiazepines. Catatonia, this is beyond the scope of this talk, and I'm actually preparing another video. It's an uncommon psychotic symptom that responds very well to anxiolytics. Check out that video, it's fascinating stuff. What are the problems that we get with benzodiazepines? What are some of the unwanted side effects, things we have to worry about? Well, cognitive dulling is chief among them. A lot of times people taking benzodiazepines during the day, especially for performance anxiety, say they take it before meetings and before presentations, need to be aware that it can actually detract from their concentration, their ability to remember. Forgetfulness is definitely a feature, and outright confusion if you take enough of it. And then the anterograde amnesia that I spoke of earlier, where the amnesia is anterograde. It's everything after you take the medication, if you're going to forget something. Anterograde amnesia is essentially blackout. Disinhibition is also a problem, so people making poor decisions, just bad judgment, embarrassing themselves. That can happen with too much alcohol at a party. It's the same phenomenon. And it's why alcohol and benzodiazepines are both equally effective at reducing social anxiety, specifically that specific type of anxiety, because you're less inhibited and less worried specifically about what other people may be thinking about you and how you're coming across. That specific concern, there must be special neurons dedicated, special circuits dedicated to that specific concern, because those that are malfunctioning in patients with social anxiety, people feel better equally with alcohol and benzos at parties. Another consequence of disinhibition is late night snacking. People, and Ambien is notorious for this because it's short acting. People tend to wake up a lot with it, and then they're disinhibited. And people who have a food addiction, or you don't even really have to even have an eating disorder, but if you're a foodie, if you're somebody who really food is always a temptation, you're always having to resist that temptation. A lot of times when you're under the influence of benzodiazepines, you're disinhibited, so you're not even trying to resist temptation. You're not worried about the consequences. And so that takes the form of people getting up in the middle of the night and hitting the fridge. So that can happen because you're taking a sleeping pill that isn't keeping you asleep. Speaking of sleep, sedation can be a side effect if we don't want it, if we're trying to treat anxiety or spasticity or some other indication, but you get sleepy. That's a dose-dependent phenomenon. It indicates that the dose is too high. Sometimes it's hard to find that sweet spot where you have enough to treat whatever you're trying to treat, but not so much that it's making you sleepy. You do develop tolerance to sedation, however, and that's what makes it such a problem when you use these agents as hypnotic medications, i.e. sleeping pills, because people develop tolerance to the sedative effect. Fatigue and depression have been reported with benzodiazepines, hypotension, low blood pressure, dizziness, ataxia, which is a gait disturbance, slurred speech called dysarthria, and weakness. Signs of dizziness and not being able to walk straight or stand up straight or bumping into walls and slurring your speech. That again, that's not so much side effect as intoxication. You're intoxicated with the medication. The medication is toxic. You got too much of it on board, but they are direct effects that we don't want. So technically they're side effects, I guess. And it's usually an indication that you're awake and up when you shouldn't be. When you've taken a hypnotic dose and it put you to sleep for a little while, and then you woke up and for whatever reason got out of bed and now you're stumbling around. Either that or you're abusing the medication or you took an intentional overdose. Paradoxical reactions are always possible. Hyperexcitability and nervousness have been reported rarely. Often this is due to rebound. So you might have a person who's taking Xanax, for example, and then in between doses will have it. So that's not so much a paradoxical reaction. That can be explained physiologically. But some people have reported paradoxical anxiety or agitation when they take these medications. You might also have a paradoxical reaction, especially behaviorally, in those patients who have dementia, moderately advanced or advanced dementia, because they become disinhibited or confused, and so you may see more agitation with those individuals. You also have to be very careful about falls. Patients with a history of a seizure disorder who are being treated with benzodiazepines for seizures may seize upon withdrawal, especially if the withdrawal is abrupt. Now, benzodiazepines are not approved for the treatment of seizures all by themselves. Where they are approved, they're approved as adjuncts. So you're giving the patient an anticonvulsant, Dilantin say, and you're using the benzodiazepine as an adjunct. Still, you have to be very careful about withdrawing too quickly. If you have a high enough dose and a person is physically addicted to benzodiazepines, withdrawal seizures are possible, but they're especially likely in a patient with an underlying seizure disorder. Benzodiazepines can exacerbate angle closure glaucoma. They affect the pupillae muscles by relaxing them, and that relaxes the iris and dilates the pupil, which in patients with narrow angle glaucoma could create an ophthalmic emergency. Pregnancy. Like alcohol, we frown on using benzodiazepines in pregnancy. They're not major teratogens. However, there is some question about whether or not they increase the incidence of cleft palate. But I'll never forget treating a young woman who was pregnant, and she was hospitalized with us for over 8 weeks, 8 to 12 weeks, and we could not settle down her mania. She was very agitated. We had to give her almost on a daily basis injections of Ativan to calm her down and to get her off the tables. And so it was a risk-benefit analysis. We had to give her day after day after day injections of Ativan, along with other medications, mood stabilizers, to get her to calm down. And she finally did and was discharged after a couple of months, and her baby was fine. So it's not to say that you should take Ativan every day when you're pregnant, or definitely don't, but they're not major teratogens. Long-term use of benzodiazepines in general is controversial in specialty fields. I myself have successfully treated individuals for decades, and there's some speculation about whether it may increase the incidence of cancer and dementia. It certainly sounds scary, certainly worth looking into, but it's not been established. And I think, again, a risk-benefit analysis, if it improves the quality of a person's life drastically and they can function, then you're not going to worry about this speculation that it might increase the probability of dementia. I'm going to address that in another video. Whatever else, you do want to be conservative. Use the lowest possible effective dose for the shortest possible period of time. This is called benzodiazepine sparing strategy. And you want to continually assess the need for continued treatment. All of these medications are Schedule IV medications, so they can be abused and they are controlled substances, but of the 5 schedules, they're only Schedule IV. The higher the number, the less controlled. The risk of dependence probably does increase with the dose and the duration of treatment for most people, but some people are just at significantly higher risk than others, simply genetically, just as with alcoholism. So some people are just way more at risk than others. According to the Neuroscience Education Institute, benzodiazepine-dependent anxiety patients and insulin-dependent diabetics are not addicted to their medications. When benzodiazepine-dependent patients stop their medication, disease symptoms can reemerge. Disease symptoms can worsen, rebound, and or withdrawal symptoms can emerge. I like that. I like this notion of we don't blame diabetic patients and say they're addicted to insulin. Some patients, albeit a minority, need chronic benzodiazepine therapy for severe social anxiety, refractory generalized anxiety disorder, panic disorder, etc., despite the fact that we're also treating with SSRIs, which is the gold standard. I certainly have had patients that I have to give them, they have to take benzodiazepines in multiple doses throughout the day, every day. And it's justified in those individuals, and they're calm and they can live, and they're not debilitated by anxiety. Again, those are in the minority. There definitely are those patients who just like taking benzodiazepines and don't really need to be taking them. And I always tell my patients, I'm always happier if they're taking 2 milligrams of Xanax a day. And it doesn't matter to me how they divide that up, but I feel better about it if the bulk of it is at bedtime. So I'm happy to treat them with 2 milligrams of Xanax at bedtime for sleep indefinitely for years and years and years, as long as it's working, as long as it's getting them to sleep. We're not having to escalate the dose and they wake up in the morning feeling refreshed and good to go, as opposed to having insomnia. Ideally, we wouldn't be affecting sleep architecture by using Xanax like that. But when they're using 2 milligrams a day and it's throughout the day, that's a gauge. That tells me that they're having clinically significant anxiety all day long, or maybe they are, or maybe they're just in the habit of taking their medication. So I need to take a look at their Prozac or whatever and figure out, why are they needing so much Xanax during the day? And in a minority of patients, they just do. They have a refractory condition. But in a lot of other patients, when we start treating them, that's how they're taking the Xanax. And then once they get better with the Prozac or the Zoloft, if you don't tell them, only take that Xanax as needed, especially during the day. You're taking a sedative, a tranquilizer during the day while you're at work or at school, you better have a good reason. Be on the verge of panic. You need to be on the verge of being overwhelmed, or else really seriously anxious, and not just because, oh, it's time to take it, because you're in the habit of it. So I do tell patients that we should really try to wean diurnal dosing if at all possible. And in most patients, we can do that. But patients should not be denied effective medication by their psychiatrists, by their specialists. So those who need them, need them. Thank you for tuning in. Please look for individual videos on each of these medications, and comments are always welcome.